And on to the second part of this lecture. Sorry, I cut off so abruptly, I ran out of time. So you add these chemicals in with the penicillin so that they're more effective against the bacteria that have beta-lactamase enzymes to break down those beta-lactam rings. So then it's more effective. And the chemicals themselves bind with the beta-lactamases and prevent that enzyme from breaking down the penicillin. So it's still effective. And some of our examples, right, are Zosyn is commonly seen. Augmentin you'll commonly see, right? The mechanism of action of penicillin, it literally enters through that cell wall and binds to penicillin binding proteins and then disrupts the cell wall synthesis, and the cell cannot live after that, right? So it causes the bacteria to die. It's bactericidal. They don't kill other cells in the body, but they're very effective at killing bacterial cells. For my penicillin indication, right, to prevent and treat infections caused by susceptible bacteria. Remember, they're very effective against gram-positive bacteria, which my streptococcus, my enterococcus, my staphylococcus, like Staph aureus, right? We are often running into these cocci groups, and so penicillin is incredibly useful for humans. There is a chance of allergic reaction, right? You've got 4%. Up to 4% of allergic reaction. And if they're allergic to penicillin, they may also be allergic to cephalosporins because of that beta-lactam activation. And so there may be a little cross allergic reaction. So just being aware and monitoring closely. So, oh, look, we're on to monitoring. So you're going to monitor for 30 minutes after you administer to look for those allergic reactions, pruritus, angioedema, right? Any shortness of breath. And then intervene appropriately, right? If they get a little bit of itching, you may have to start adding an antihistamine, like a Benadryl. And this may not be something that they could take in the future, right? Because that's my first introduction, and then the second would be causing that allergic reaction, right? Effectiveness of oral penicillins decreased when you're taking caffeine, citric fruits, sodas, fruit juices, tomato juice. And so you want to make sure you have it with a nice big glass of water. Onto my cephalosporins. So just like with penicillins, if you see the suffix of "cillin," right, you typically are talking about a penicillin. If you see the prefix of cepha, something like that, you're usually talking about a cephalosporin. This is a semi-synthetic derivative from a fungus, and it has similar properties structurally that to penicillin. So if you're allergic to penicillin, you may have a little cross allergy where you are allergic to cephalosporins. So just be careful when you're administering a cephalosporin if they have a penicillin allergy. And just like penicillins, the cephalosporins are bactericidal, meaning they kill the bacteria itself, and they're nice and broad spectrum. Now, my first generations have great gram-positive coverage, poor gram-negative coverage, and as you raise up through the generations, you will have better coverage typically, or more specific, and then you tend to have an increase in cost too, because they become more and more refined. My first generation used for surgical prophylaxis, and we use it all the time, ANSEF IV. So you have appendicitis, and you're going to have to go to surgery to get that cut out. It is very common that you get ANSEF before you go under the knife, right? So it's prophylactic as you're going into the OR. And then Keflix for otitis media. There's a couple indications for Keflix actually, but on to our second generations. They're good gram-positive, better gram-negative than the first, but still not so great. We use them also for the surgical prophylaxis and abdominal or colorectal, and you'll see that. You actually will see Keflix as well used for those two. Third generation, this is the most potent group against my gram-negatives, but they're not as effective against gram-positives. These guys can cross into the CSF, right, through my blood-brain barrier, so they can treat infections within my dura mater, inside my CSF. So that's very important on my third generation cephalosporins. Fourth generation, broader spectrum against gram-positive, and these are the newest ones, and we are seeing a lot of cefepime or maxipime, and so it doesn't always hold true, but usually when you see the cepha, you're talking about a cephalosporin. Oral administration should be given with water always, right? But you can do food because of that GI upset. A lot of the antibiotics have GI upset, nausea, vomiting coming with it. The cephalosporins have an off-label use, though. Some of them work as an antabuse-like reaction, meaning if you drink alcohol, then you have rampant vomiting immediately after. And so off-label use, it is to dissuade people who have issues with drinking alcohol from drinking alcohol because of the reaction that they'll have. On to my carbapenems. These are very broad-spectrum antibacterial. They have that same clavulanic acid to disrupt the beta-lactamase enzymes that are used to protect themselves, bacteria used to protect themselves. And these are far more dangerous, right? They're more complicated body cavity connective tissue issues, so we use it for, bones, joints, skin, soft tissue infections. And the big risk is seizure for carbapenems. And so this is an IV drug, and they are going to be admitted to the hospital if they're needing to get a carbapenem. And now I'm on to my macrolides, right? These ones are common, right? Azithromycin, erythromycin, clarithromycin, you guys see these all the time. They're bacteriostatic, and in high concentrations become bactericidal. The reasons why you'll see these would be strep infections, very common with my strep infections. You may see these with moderate respiratory infections, and then the more severe STIs, right? So syphilis, Lyme disease, gonorrhea, chlamydia. Usually with like syphilis and Lyme disease, they may tack in another antibiotic, and you'll have double antibiotic therapy to kind of tackle the problem. Adverse effects, usually primarily erythromycin is the one that's going to give you that GI upset, nausea, vomiting, diarrhea, and then hepatotoxicity, right? Your liver enzymes begin to elevate because it's a little hard on your liver to break them down. Now to my tetracyclines. These are bacteriostatic. These are broad spectrum. The big thing is that they actually alter the binding with calcium, right? Strong affinity for calcium, so they cause a discoloration to the teeth. So little babes shouldn't take it because their bones and teeth will turn yellow. Pregnant women shouldn't take it because the babe developing will have a delayed skeletal development, and so they will be osteoporotic, basically. They'll have these weak little baby bones. And so you would not see this with little people and with pregnant people, or lactating women, right? Because they're giving it to their babe through their breast milk. And so you're going to have the same issue of tooth discoloration. So just beware. This is a wide spectrum. It does both gram-positive and gram-negative. And you've got a whole bunch of things that it treats: anthrax, right? Mycoplasma, chlamydia, Rocky Mountain spotted fever, syphilis, Lyme disease. It's peptic ulcer, right? H. pylori. So tetracyclines are awesome, but they've got some issues with them. You'll also be careful with photosensitivity, right? Those are the main pieces: are staining your teeth and bones and photosensitivity. Here's some of my examples of tetracyclines, right? And you can see the cycline as that suffix that kind of trigger you to think, I think this is a tetracycline. Careful when you are taking the actual medication itself, because milk products, iron preparations, antacids, these all bind and deactivate the tetracycline. So you'll want them to drink water with it and avoid milk until, usually about 20-30 minutes, because it will deactivate the actual medication itself. And again, we're coming back, my photosensitivity, so avoid your sunlight and tanning beds while you're taking your tetracyclines. And now for my aminoglycosides. These are very common. They're commonly used, and they're usually used in combination with other antibiotics for synergistic effect, right? So that together they have a more potent effect against the pathogen. Mostly gram-negative, some gram-positive. These are bactericidal, and they have serious toxicities that come with it, right? So you're going to be monitoring these closer. Usually you'll see them in combination, right? Penicillin, cephalosporins, and vancomycin, those mycins in combination with the aminoglycosides, because they're the more potent, against the more potent pathogens. certain gram-positive infections are resistant to other bacteria or other antibiotics, and so you'll add on an aminoglycoside, another indication. What you're going to be concerned for, right? Ototoxicity, you can have temporary or permanent hearing loss and balance problem because of that. Your cochlear apparatus inside your little brain and ear is how you determine your sense of balance in this world. Nephrotoxicity, this is a big issue, right? This is your kidneys will no longer function. You'll start to see the rising serum creatinine, and you'll want to watch carefully their renal function, their function, BUN and creatinine. Monitor the peaks and troughs. Every 3 days while on therapy, you're going to do a trough level, which means 30 minutes before you administer that antibiotic, you're going to draw blood, right, to get the lowest level before you administer the antibiotic. And here are some of my aminoglycoside examples. Gentamicin, we see all the time, right? Neomycin, streptomycin, tobramycin. We see these very frequently in the hospital setting, right? Because there is no PO form. There's really poor oral absorption. So these are all given IV, right? So these people are going to have to stay in the hospital, and you're going to monitor their troughs. And same thing, poor absorption through the GI tract. Neomycin, you can have some, but generally you're going to see these given IV, right? And all of these can cause those toxicities we were talking about, the ototoxicity and tinnitus and nephrotoxicity. And so you're going to monitor them closely to make sure it is therapeutic levels and does not elevate to toxic ranges. You're also going to watch your kidney function at the same time. So monitor your peaks and troughs, and then look for the symptoms, right? Dizziness, hearing loss, tinnitus, people will call it tinnitus, but the ringing in the ears. And then symptoms of nephrotoxicity, urinary cast, you won't see this, but you'll see the casts themselves on the UA, on the urinalysis, as well as the proteinuria, and then increasing BUN and serum creatinine. Now we're moving on to my fluoroquinolones. They're also called quinolones, but fluoroquinolones way cooler, right? Excellent oral absorption on these guys. They're that absorption is reduced by antacids, right? Similar to my tetracyclines. They are effective against my gram-negative and some gram-positives, usually protozoa. C. diff is where you'll commonly see these fluoroquinolones. They are bactericidal, right? So lower respiratory infections, bone, joints, UTIs. This is not the first line for UTIs, but it is commonly used, especially if you failed on the first line treatments for UTIs. And then infectious diarrheas, STIs, and anthrax again. Here's some of my examples. Cipro, I'm sure you've seen Levaquin, right? Levofloxacin. So you're seeing that same suffix to indicate it's a fluoroquinolone. You're going to have that floxacin typically at the end. I've moved my cursor. Other antibiotics that you will commonly see, clindamycin, right? Cleocin, it's gram-positive anaerobic infections, so chronic bone infections. Intra-abdominal infections. This may cause pseudomembranous colitis, where the actual lining of your colon, right, is changes a little bit in its actual formation, and you have rampant diarrhea typically with this. Dapsone, this is used for leprosy. You don't see this as commonly in the U.S. Pneumonia associated with AIDS and HIV, because these tend to be opportunistic, right? And then Zyvox, this is used to treat vancomycin-resistant Enterococcus faecium. This is hospital-acquired, and so you'll see Zyvox with my really resistant pathogens. It can cause hypotension, right? And then serotonin syndrome, so beware. Other antibiotics I've got macrodantin, right? Nitrofurantoin. Usually this is for UTIs because it's effective against E. coli, Staph aureus, Klebsiella, Enterobacter. Use carefully if the renal function is impaired. So if they don't have good renal clearance, if they have a high BUN creatinine, you're not going to be seeing these as much. And then vancomycin, you guys are already pros on. Be careful for my red man syndrome, nephrotoxicity. Another one you're going to infuse slowly, and you're going to do your peaks and troughs. I'm running out of time. Okay. It's essential to do cultures before you actually administer the antibiotic. And as you are administering, watch for anaphylaxis, for allergic reaction, right? Look at the patient history, what meds are they on, and any potential